Now I pass to Horst. He will introduce the next technique and the next center. Please, the next slide.
Now we will talk about robotic endoscopic resection, and it's a pleasure for me to introduce Philipp Chiu. So he is from the Chinese University of Hong Kong, from the Department of Surgery, is also chairman of the Department of Interventional Endoscopy, and is associate dean of the university. So a lot of important positions, and we are looking forward to your presentation, Philipp.
Hi, I'm Professor Philipp Chiu from the Chinese University of Hong Kong. So today I'm happy to share with you a patient with a lateral-spreading tumor in the sigmoid who have received endoscopic submucosal dissection by Endomaster Ease System. So this is the new robotic system, which is called the Endomaster Ease System. It has a true robotic arm passing through a flexible endoscopic platform that can be used for performance of endoscopic submucosal dissection in the colon. So this location is at the sigmoid colon at around 20 centimeter from the anal verge. So we first insert the robotic arm and into through the true working channel, which is located over the 6 o'clock and also the 9 o'clock position of this flexible system. So the video is being played at the 4x speed. This is a whole video of the procedure. So the video lasts for 10 minutes. So altogether, we finish the procedure in around 15 minutes time. So firstly, we perform the ESD procedure is similar to what we are performing for all types of ESD. So we first perform the initial mucosal incision, and as commonly performed for all colorectal ESD, we do not need to open up the whole circumference. So you can see that we have already pre-injected at some mucosa using the Boston Scientific Oral Gel. And after injection and lifting of this lesion, so we've performed the mucosal incision using the right robotic arm with the cautery knife at the end. So you can see that this lesion is probably around 3 centimeter in size. And we use the CO2 for insufflation and provision of the space, and also to use the antispasmodic. As you can see, previously there are significant colonic spasm, but right now we have already stopped the contraction of the sigmoid colon. And the initial phase of the mucosal incision should be adequate to allow the mucosal pickup by the left arm. And then afterwards, with the lifting, then we will continue the submucosal dissection, as you can see here. So a lot of the time when we are performing the dissection, we can in fact change the position of the retraction arm so that to allow a better exposure at different area during the submucosal dissection. So sometimes we will not be able to achieve a good grasping because of the positioning. So we need to adjust the scope position, and also sometimes with the patient positioning as well. So when we are performing the submucosal dissection, you can see that we are now exposing at the submucosa and clearly demonstrating the muscularis propria layer. So we would have to avoid injury to the muscularis propria layer. And with this kind of robotic arm for lifting, we can see very clearly at the submucosa and also the muscularis propria layer. And sometimes when we can see that there's inadequate lifting, we can further inject by injecting the solution through an accessory channel, as you can see here. So even during the process of submucosal dissection, we can insert the needle for further injection of any submucosal solution. So now we encounter a major blood vessel. So we use the cautery knife and the coagulation mode to coagulate before we cut on the blood vessel. So this process is quite different from the usual ESD procedure in that during the usual ESD procedure, our scope and the dissection plane is really close to our eyes, while in this procedure, we are adopting the surgical principle with the use of the two arms for the lifting and exposure before we cut, while our eyes are in a more at a distant and a stable manner. So, during the retraction, we are not only lifting up the mucosa, sometimes we can able to retract at a different angle and dissection over the submucosal space, as well as we will be able to expose adequately to avoid damaging the muscle layer. So a lot of time we are not only lifting or retracting, sometimes we are compressing on any structure within the colon. So for example, not only compressing on the tumor for exposure, but maybe also compressing on the colonic wall for the exposure. So you can see that gradually we are dissecting over the submucosa, and sometimes bleeding can encounter during this process, but we can stop the bleeding with the trochlotry knife, or sometimes we just avoid the area of the bleeding and continue the submucosal dissection. And that is certainly possible because we can work in different area by use of the two arm without focusing on just the local condition. So unlike a conventional ESD, we can actually go away from the bleeding site. And you can see here with the adequate lifting, the submucosa is nicely exposed and demonstrated. And of course, we have to also adjust our lifting and also the procedure direction towards the colonic wall, because the colonic wall is not a flat, but it's in a curvature. So during the dissection, we have to try to avoid the cutting into the mucosal, the rectal, the sigmoid wall. And you can see that sometimes significant bleeding can encounter, and we are trying to use the cautery tip to achieve a good hemostasis. But of course, if there's really significant bleeding, we'll be able to use other instruments through the accessory channel like the coagulation plasma to achieve a good hemostasis. But as I mentioned, sometimes we can just avoid that the bleeding point and go to the next area for dissection rather than to focus on doing hemostasis, because a lot of times these are bleeding from a very small vessel. So we will be able sometimes stop by itself. So, and we have to also pay attention to the tumor border, and because sometimes we may be cutting into the edge of the tumor. So definitely important is that when we are retracting, sometimes we're not able to see the tumor border. So we need to expose adequately in order to allow us to recognize the tumor border. And sometimes the endoscope also have to uh, accommodate its own position so that it can allow our exposure adequate to the seeing the, especially on the posterior wall, posterior side of the specimen, so that we can recognize the border of the tumor. So right now, as I can retract and see the tumor border, I will continue lifting up the mucosa. And a lot of time we may not only be able to lift up, but to also trying to push away the lesion so that we can have a better exposure at the base. And of course, don't forget we'll be able to inject more by the accessory channel and continue this dissection. So if the position is not well, we can then readjust, and sometimes we will be able to retract at the base over the submucosal side. So like here. So the same as the conventional ESD, when we are dissecting at the very end, sometimes it's difficult because it is becoming a lot more floppy, and so that we'll be moving around the tumor, which is almost detach from the all the attachment. So right now I'm not only trying to grasp it, but also to push away. So this is almost like the final part of the dissection. So we'll be able to perform the submucosal dissection here. And also you can see I'm trying to lift up the lesion in different direction. So to overcome the mucosal fold, especially over the anterior side of the camera, we can actually push down the specimen and then expose the most far end of the mucosa, and then complete the mucosal incision like that to ensure a good resection margin, and then also to try to cut here at the submucosa. So this is almost the final part of the cutting. So now we have completed the dissection. The specimens demonstrated a tubulovenous adenoma with severe dysplasia, but the margins are clear, and both for the lateral margin and the deep margin. And the final part is that we can retrieve the specimen using the same robotic system. So this is the final end.
Thank you, Philipp, for this.
So thank you very much.
Okay. For this excellent demonstration. This is a very impressive technology, and I think you already discussed the potential advantages and maybe also limitations of this technique. So could you just shortly comment on the learning curves? This looks more like a laparoscopic approach, and you have a lot of experience with flexible as well as with rigid endoscopy and robots. So do you think it will be easier for surgeons to learn to use the robot compared to flexible endoscopists?
Thank you, Horst. I think from my perspective, this is a really first prototype. So it is quite difficult to comment at this moment about the learning curve. So I can only say that from my experience now, we have 29 patients receiving this procedure. At the initial 15 case, it is almost like our learning curve because we need to learn how to control the robot, how to position, how to grasp with the best direction of the retraction and also the dissection. So we have experienced a lot about how we can retract and expose the submucosa. I think that's the initial 15 case, but I believe that this probably an enhancing technology. So I guess even any endoscopists who have the knowledge of ESD will be able to master.
Okay, thank you very much. We are looking forward to more results and experience and also learning curves in other centers. Thank you. Unfortunately, there are still many questions, of course, but we have to proceed. Thank you for joining us, and all the best. See you at another occasion, hopefully in reality, Philipp. And
thank you so much.
Thank you.